A very good day. My best wishes to my respected seniors and my dear friends. The topic given to me is the OXIS classification of the interproximal contacts of the permanent teeth. And I am Vignesh Kailasam, the Professor and Head of Orthodontics from Ramachandra Institute of Higher Education and Research. A special thanks to Professor M.S. Muthu for this opportunity. I wish him the very best and the team for a fantastic success of CECCRe 3.0. The 6 keys to normal occlusion were proposed by Lawrence and Andrews. There is substantial literature on the 5 keys except for the 5th key, which is the tight contacts, in which there is very minimal literature. The 5th key, that is tight contacts, refers primarily to the nature of the interproximal contacts. Muthu et al. Have shown the importance of this tight contact in that it is necessary and important to maintain the integrity of the dental arches and the health of the supporting structures. They have proposed the OXIS classification in the primary molars, where the alphabet O stands for an open contact, that is, the teeth do not approximate, an X contact, which is referred to as a point contact, in which there is less than 1.5 millimeters of approximation, a straight contact in which there is greater than 1.5 millimeter of approximation, but the contact is straight, and an S contact, which is similar to an eye contact except when it is curved, and thus they came up with the acronym OXIS. Subsequently, RT et al. Used this classification, which was modified for the anterior teeth, where basically the S type of contact was modified into S1 and S2 depending upon the amount of the quantum of the rotation of the anterior teeth. The impetus for a permanent dentition classification, which we did, was based on these studies on OXIS contacts, and we have validated this OXIS classification for the permanent dentition. The clinical implications are that it could play a significant role in plaque accumulation leading to caries formation. The I and S types would be inaccessible for mechanical cleaning when compared to the O and X types, and Muthu et al. Have shown that the S and I type of contacts had higher odds of developing caries compared with the X and O types in the primary molars. Coming to orthodontics, there is controversial literature regarding whether fixed appliance treatment as such, that is, when the patient is on fixed appliance, whether it increases the risk of caries because of the lot of attachments onto the teeth, making it difficult for the patient to clean, or whether orthodontic treatment results in lesser caries risk. The literature is divided, with a few studies showing that the orthodontic treatment increases the caries risk, whereas other studies have shown that the orthodontic treatment, that is fixed appliance, is not the sole factor in increasing the patient's risk during orthodontic treatment. Thus, we hypothesize that the type of contact could make a difference to this varying literature. With the OXIS classification being a new and interesting classification of the contacts, it is plausible to hypothesize that teeth with broader contacts and rotated teeth could be at a higher risk of caries formation in the fixed appliance patient. So we designed a study and got institutional ethical committee approval. 30 patient records were taken at 3 time points, that is at baseline, that is before orthodontic treatment, referred to as T0, at the time of debonding of the fixed appliance treatment, that is at T1, and 1 year after treatment, that is at T2. The inclusion criteria were full complement of permanent teeth other than third molars and an age of 14 to 25 years to prevent any incidence of attrition and undamaged interproximal contacts. The exclusion criteria were the occlusal wear, any morphological abnormalities, and any dental caries. So this was our original validation of the OXIS classification, where you can see representative images, O implying that there was an open contact, that is, the adjacent teeth did not approximate, X implying that there was a point type of contact, I implying that there was a 1.5 millimeter straight contact, and S implying that there was a curved contact of greater than 1.5 millimeters. As mentioned, RT et al. Had modified the S type of contact into S1 and S2. S1 when the tooth was rotated and only one of its surfaces was in contact with the adjacent tooth, and S2 when the quantum of rotation was more, that is, when the tooth was rotated and 2 surfaces, that is, both proximal and labial, were in contact with the adjacent teeth. So 2,340 contacts, that is 780 at each time point, 780 at baseline, 780 after fixed appliance treatment, and 780 after treatment, that is 30 patient contacts were collated, and ANOVA analysis was used to assess, and routinely a p-value of less than 0.05 was deemed to indicate statistical significance. Once again, just a brief summary of the various patterns. This is for the maxillary posterior dentition. We can see the O type of contact, the X type of contact, wherein there is a point contact. A contact of greater than 1.5 millimeters was designed as I, and a curved contact was named as S. Similar representative images in the mandibular posterior region, mandibular anterior region, where the S alone was modified into S1 and S2, and similarly for the mandibular anterior region. Coming to our results, so here you can see the treatment at 3 time points, that is at baseline, at T1, that is the end of orthodontic treatment, and at T2, that is after 1 year of retention. So here you can see the representative cast images and the equivalent clinical photographs at T0, T1 and T2 of the maxillary posteriors. So we can see that an X contact has become an I contact, which has become an eye contact at the end of 1 year. Similarly, for the mandibular posterior regions, the topmost image represents the pre-treatment, that is at T0, where we can see an I type of contact, which is changed or after treatment into an S type of contact, and which has maintained at the S type of contact after 1 year of orthodontic treatment. So pre-treatment was T0, post-treatment was T1, and 1 year post-treatment was T2. For the mandibular anterior segment, so we can see the contact between the lateral and the central incisor, where there was crowding and rotations. So the S1 contact became an X contact at the end of treatment and remained as X contact after 1 year of retention. Similarly, for the mandibular arches, an O type of contact as seen between the canine and the lateral incisor. With orthodontic treatment, the contact has closed, has become an X type of contact, and after retention, that is 1 year post-treatment, it is still maintained at the X type of contact. So these are all the representative images from about 30 patients who were followed up at 3 time points. The results showed that for the second molar, first molar contacts, the S pattern had the greatest at pre-treatment, which was maintained at 1 year following treatment, and which changed to I pattern at retention, showing that the I pattern was kind of a little more stable, or the S pattern changed to I pattern at the end of treatment. For the first molar, second premolar contacts, we saw similar results, and we could see that the I pattern was the most common, which maintained at T0, T1, and T2, whereas the X pattern, which was slightly more common at the pre-treatment, remained, which was a combination of I and the S type of treatments at T1 and T2. So for most of the posterior contacts, the broader contacts were the norms, that is the I and S pattern at T1 and T2, whereas at T0, the X pattern was seen as a second most common pattern. For the anterior teeth contacts, the open pattern followed by some minor rotations, which was the S1 pattern, was seen. At the end of treatment, we saw the X and the I pattern, which was maintained for most of the anterior dentition, and for the midlines, where the X pattern and the O pattern were more common at T0, whereas the X and the I patterns were more common at the end of treatment and 1 year following orthodontic treatment, and for both the maxillary and the mandibular midlines. At T1, that is immediately after fixed appliance treatment, correction of the malpositions resulted in a change in the interproximal contacts. For the maxillary and mandibular posterior teeth, the O and X patterns were corrected to I and S patterns, indicating that broader contacts were the norm at T1. For the maxillary and mandibular teeth contacts, the O, S1 and S2, that is the anterior teeth contacts, were corrected to X and I patterns at the end of orthodontic treatment. The mandibular interproximal contacts had a greater prevalence of X patterns than that of the maxillary contacts, and this we felt could be due to the smaller size of the mandibular teeth, which led to a smaller interproximal contact. Although the contacts in both the posterior and anterior regions were similar at T1 and T2, that is at the end of orthodontic treatment and 1 year following treatment, minor changes were observed. These changes were greater in the mandibular arch than in the maxillary arch. So what were the minor changes which were more commonly observed in the mandibular teeth? These were seen in the posterior dentition, where an I pattern changed to an S pattern or vice versa. These changes in the contacts at T1 and T2 could either be one of the two reasons. The first reason being an improvement in the occlusion during the settling period, or it could be relapse. We could not compare our results at T1 and T2 as there were no similar studies, and ours was the first to assess the variation in interproximal contacts after orthodontic treatment. As mentioned, the second reason for these possible changes could be relapse, as relapse is any change in tooth position after orthodontic treatment away from a corrected malocclusion. More changes were observed, as mentioned, in the posterior mandibular interproximal contacts, and the reason could possibly be due to the retention protocol, where we had advised maxillary S6 retainers with full-time wear with a mandibular canine-to-canine fixed lingual retainers. This combination was chosen, and these are the most prevalent combinations for retention following fixed appliance treatment. This protocol could have possibly allowed posterior interproximal changes in the mandibular arch. The settling of the occlusion or relapse could have been also a factor, and that is because the residual forces following treatment remain in the periodontium after tooth movement. Drayton et al. Had shown that while reorganization of the periodontal ligament fibers takes over 3 to 4 months, the gingival collagen fibers takes about 4 to 6 months to remodel, and the elastic supracrustal fibers can take up to 232 days or nearly 8 months. Thus, Drayton et al. Has said that the first 8 months following the treatment is critical. So we followed these patients for almost a year after treatment. The strength of our study was that this was the first study to assess the variations in contact after orthodontic treatment. The mechanics were standardized to a non-extraction treatment plan. The retention protocol was also standardized to an upper S6 and lower arch being a canine-to-canine bonded retainer. The limitations of our study were that the third molars were not considered either in the initial occlusion or during the follow-ups. The initial malocclusion, that is, whether it was class 1, class 2 or class 3, were not standardized, and definitely the variation in interproximal contacts with premolar extraction protocols would provide additional information. The future research would be based on these results would be to study a larger sample with a longer follow-up period to provide more clinical information on the changes in interproximal contacts over time. This would be of great significance since it would give us more information on the relapse and the stability of the contact. Further, caries risk assessment of the various patterns of the interproximal contact would be of great clinical interest to the clinician, since Murthu et al. Have reported that the S and I types of contacts in the permanent in the primary molars have higher odds of a caries development. So to conclude, in our study, the interproximal contact changes from T0 to T1 changed from point, that is X type contacts, and O type of contacts, which were observed at T0, while broader contacts, that is the I patterns and the S patterns, were observed at T1, that is immediately after orthodontic treatment, and T2, that is 1 year following orthodontic treatment. While most of the contact patterns were maintained at T2 when compared to T1, the changes in the interproximal contacts between I and S were observed. That is, the I type of contact became S and the S type of contacts became I. These changes were more frequently observed in the mandibular arch rather than the maxillary arch. These are my references. Once again, thank you for your patient listening, and I would like to thank once again Team CECCRe for giving me this opportunity to talk about the importance of the OXIS classification in the permanent dentition. If you have any questions or any doubts, I will be most happy and glad to answer. Thank you so much.